because it was our first time working with ketogenic diet, we were not confident that it could be so powerful as it showed in the end.
A new pilot study looking at ketogenic therapy for moderate to severe depression was just published. And again, we see really remarkable results. Now, of course, it's a small study. It was a pilot study. And when it was designed, it was one of the first of its kind. So it couldn't be randomized controlled trials, but the results are remarkable. And what comes next? Well, I'm interviewing Dr. Elisa Brietzke, who's a professor of psychiatry at Queen's University, and where she's a clinician and a researcher. And we talk about her journey, what motivated her to do this study in the first place, and a lot of the challenges of organizing the study, especially around the time of COVID, but how she pulled it off as a remote intervention, which showed feasibility, which showed remarkable effectiveness, not just for depression, but also for anhedonia. So we get into that and how other treatments don't address that so well, and what this will mean for future studies, and whether this should be first-line therapy for treatment of depression. We get her opinion on that. So really an interesting interview about the study and about the future of ketogenic therapy for depression. So I hope you enjoy this interview with Dr. Elisa Brietzke. All right, Dr. Elisa Brietzke, welcome back to Metabolic Mind. It's great to see you.
Great to see you too. Thanks, Bret, for inviting me.
Of course. So I'm excited to talk about your paper, Medically Supervised Ketogenic Diet as an Adjunctive Treatment for Moderate to Severe Depression, which was published in the Journal of Affective Disorders. But before we get into the results, which are quite remarkable, and I definitely want to talk about the results, I want to talk about the background of what led you to study this. Because at the time when you embarked on this, Dr. Sethi's paper out of Stanford wasn't published. Dr. Campbell's paper out of Edinburgh wasn't published. Dr. Volek's paper out of Ohio State wasn't published. So in a way, you were sort of trailblazing with them as you embarked on this study. So what encouraged you or motivated you to even look at ketogenic therapy for moderate to severe depression?
Yeah. So what happened is that since my PhD in 2009, I have been working in ways to reduce inflammation in bipolar disorder and in depression. In my PhD, I measured some cytokines, some inflammatory molecules in the blood, and we saw that people during manic and depressive episodes, they had like a pro-inflammatory state, and I was interested in doing that. So in 2018, I came to Canada to work with another researcher called Roger McIntyre, which was someone who was dedicated to understand the relationship between inflammation and glucose and insulin dysregulation. So at that point, we started to look for medications and molecules that somehow could block both the inflammatory activation, but also to help with the metabolic side of things. Because at that point, we did not have any clinical trial with anti-inflammatory medications which show consistent effects in bipolar disorder and in depression. So in 2018, it was the first time I proposed a clinical trial or an interventional trial with ketogenic diet. At that point, I was familiar with some very old case reports about ketogenic diet. And it happened that in my family, I had someone with epilepsy. So I was familiar with the literature in epilepsy too. It took us a while until we were able to get funding for this study because most people were very unfamiliar with the framework of the metabolic and / inflammatory dysregulation.
Yeah, back in 2018 and 2019, really nobody was talking about it publicly or funding studies. And yeah. I shouldn't say nobody, but very, very few people. Yeah.
Then I was hired by Queen's University, where I am now, in Kingston, Ontario. And I got some money as a research establishment grant. So this was the first time that I was able to start a clinical trial. And this was the beginning of other submissions and other, funding for this program. And then I realized that to break the, skepticism of some of the reviewers, I needed to show that ketogenic diet was feasible. because every time I submitted a grant proposal, I heard from the reviewers, people with depression, they don't have enough energy to invest or to do a ketogenic diet. They are not going to comply with the diet. This is too complex. People can take their medications every day. How do you know that they will be able to comply with the diet?
Wow, that's remarkable. Without, I mean, not even knowing about a ketogenic diet, they're just going to assume people can't adhere to it and reject your proposal. That's remarkable. I mean, gosh.
And then there was a shift inside our group when we met a dietitian, which was very familiar with the diet. We had been working with ketogenic diet in epilepsy for more than 20 years. So she helped us a lot. And she had this confidence that ketogenic diet was an antidepressant because she was seeing people with epilepsy in ketogenic diet showing improvements in mood, in cognition, in the energy level. So it was, a magic moment in which we have this team with people from different backgrounds and with different experiences. So this is when we started the project.
So it started in 2019, and of course, we all know what happened in 2020 with the COVID epidemic, pandemic, and shutting down most in-person interactions, and especially for in-person research studies. So you then had to transition the study to make it 100% remote. So tell us about that transition, because dietary interventions and follow-up and getting assessments and blood work and whatever on a completely remote basis. You had to make that transition as well, didn't you?
Yeah, it was a hard decision because we wanted to include other outcomes. We wanted to have like blood work to examine some metabolic and some inflammatory molecules. We wanted to include some behavioral tests because we were especially interested in anhedonia, which is this dimension of depression related with lack of pleasure. And this is something that does not improve or very often does not improve with conventional antidepressants. So we had like a huge protocol. But at that point, nobody knew anything about the COVID and how the things are going to develop. So we have the hospital at some point, like on and off, allowing us to see patients. This is a study in which we follow the patient at least 16 weeks. So it was very hard to predict what was going to happen in 5 months, especially during the beginning of the COVID. So we have to make this decision. I was very happy that the funding agency that funded most of this study, which is called PSI Foundation, allow us to change the protocol to do everything online. And in the end, it was interesting because the ethics committee, the IRB, allow us to recruit people from anywhere in Canada and anywhere in US, as long as the person has a physician in place, a family physician or a psychiatrist to monitor the patient and to intervene if there was like worsening of depression or any side effect. So we were very happy because, it allows us to realize that it is possible to deliver this intervention fully online.
Yeah, which is remarkable. I mean, you didn't set out to prove that concept that it can be delivered online, but because of circumstances, you were forced into it and sort of proved it's very effective. So let's jump into the study. You started with sort of a 2-week run-in period, right, and then a 12-week intervention period. And how many did you start with in the run-in, and how many made it to the intervention?
Yeah, so we had a plan to recruit 10 people just as a feasibility study with a diagnosis of major depressive disorder or a depressive episode in bipolar disorder. And the plan was to include people who were taking a first line medication and did not get like a significant improvement. So instead of switching to a different medication, we decided or we offered to the person to add ketogenic diet to the combo. At that point, because it was our first time working with ketogenic diet, we were not confident, and we were not confident that it could be so powerful as it showed in the end. We were a bit afraid of discontinue the medication, give ketogenic diet as the only treatment. So we decided to do this trial as an add-on. So we included 11 patients. We had 2 people which did not complete these 2 weeks of transition. Okay. We decided to include this 2 weeks period because we know from the clinical practice, and this was one insight from our dietitian, that people do not put all the food they are eating in the trash and go to the supermarket and buy new foods. And this was the time in which it was possible for the patient to know new recipes, to make some mistakes in the market, because it takes a little bit of time to the person to start to change the way that people prepare their food, and who is going to cook at home, how the family is going to deal with someone getting a new diet. So we have these 2 weeks, and our plan was to offer 12 weeks to everyone which completed the 2 weeks phase and that was in ketosis after 2 weeks. Fortunately, all our 10 people who completed the 2 weeks, our 9 people who completed the 2 weeks were able to enter in the maintenance phase and completed the maintenance phase. So this was the first lesson of this study. The 2 weeks are the moment in which the patient needs more attention and needs more like intensive contact with the team. After the patient learns how to do the things and adapts to the diet and possibly start to observe some effect of the ketosis, it's not that difficult. It's not that hard to continue and to complete like 14 weeks or 16 weeks of the diet.
Yeah, so some of these keto intervention studies that we've seen provide meals in the beginning, and some use it without providing meals, education. So did you provide meals, or was it all up to the individuals to prepare all their own meals?
It was all up to the individuals. What we did is that we adjusted the meals and the diet to the budget that they have. So there was an analysis of how much money did they have for food, and it was adapted. It was adapted to their preferences too, and to the way that they like to prepare the food. And we had one app which is called Keto Suit, which helps the patient to deal with the ketogenic diet and also offer a lot of recipes and a lot of ways to prepare the food. So we did not provide. The idea was to start with something that could be kept with the person. So we provided like a culinary scale. We provided some kitchen utensils, and they are from the patient. They can keep it. And the idea is that we must empower the person to continue to adopt this diet in case they observe benefits. So that's the idea. We did not offer meals. We decided to teach the person how to prepare them.
So of course, right off the bat, we have to recognize this is not a 1,000-person randomized controlled trial, right? It was a 10, 11-person a single arm intervention study, which you have to do when nobody's funding it and nobody, and the studies haven't been done yet. So a pilot study. But with that caveat, the findings were remarkable. I mean, would you have 7 people go into what's considered remission, and a mean reduction of 22 points on the MADRS scale, which I'll have you explain. But tell us the highlights of the results and what you felt about them.
Yeah, so we included people who were in a level of severity of depression between moderate to severe. So we have people who are like really depressed. And all but one person reduced the depression severity to a level that we will call remission. So to a level in which the severity of symptoms will be not even enough to say that depression was still there, which was really good.
Right, and like you said, this weren't people just with quote unquote mild depression. They had moderate to severe depression, putting it into remission. I mean, that's remarkable.
Yeah. And the other interesting thing is that the improvement happened especially in the first 2 weeks, something different than most antidepressants that can take up to 6 to 8 weeks to get an effect. So it was possible to observe like an improvement relatively early in the course of treatment. All our patients were able to maintain a level of ketosis that we could say that, okay, this person is like at least with 85% of compliance with the diet. So all our patients were able to keep this, which was really good. And other symptoms also improve. Anxiety improve with the diet. The anhedonia improved with the diet too. So we had other dimensions of this depression slash anxiety slash mood, which also improve with the diet. So there are some side benefits.
Yeah, and as you mentioned, they were all on first line antidepressant therapy. So all of these benefits are in addition to antidepressant therapy and benefits that they clearly were not seeing on the antidepressant therapy. So that's pretty remarkable. Now, you've brought up anhedonia a couple times. So I want to dig in on that a little bit because frequently, if someone starts an antidepressant, their depression symptoms might get better, but that doesn't mean they're feeling joy and feeling good and really embracing life, so to speak. And I guess that's one way to sort of characterize anhedonia. But tell us a little bit more about how anhedonia is different from depression and why it was so remarkable that you saw a change in that.
Yeah. So anhedonia is usually not related to the serotonergic transmission that classically is behind like low mood and anxiety symptoms. Anhedonia is linked more to deficits in noradrenergic transmission. And we know that individuals with obesity, with diabetes, and with conditions related with a high inflammatory activation, they are more prone to anhedonia. There is like a pathway in the brain in which inflammation and also glucose disrupts dopamine transmission in the brain. And we believe that that's one reason why it's very common, incredibly common in our practice that when we prescribe an antidepressant, the patient comes back and say, I'm not feeling suicidal anymore. I can't, wake up in the morning. I'm traveling. I'm working. However, I am in the automatic pilot. I don't feel pleasure. I don't enjoy the things. I don't feel joy. And as a psychiatrist, I think it was like we want something better for our patients. We don't want that our patients just keep functioning. We want people like be happy and making their existential potential real. We want them like able to feel joy and to feel pleasure in life. So that's something I would say unique from this type of treatments, and I hope that we can confirm this in larger studies, because if it happens, it will be like, a huge advantage or a huge difference compared to conventional antidepressants.
Yeah, so for a single arm study with a motivated population, very feasible even remotely, significant improvements in depression and anhedonia and anxiety. So what's next, right? This sort of sets the stage for potential future studies and future treatment interventions. So what's next for you as a researcher and as a clinician?
Yeah, I think the next point is like to randomize, to have people examine in a randomized control setting. So this is what our group is doing at this point. And the other thing we are working in our next projects, for everyone who had a response with ketogenic diet, we are going to offer a 6 months maintenance phase. So the idea is to perhaps offer a less intensive dietetic care, like instead of seeing the patient every week, we can see the patient every month. But the idea is to see if we can keep these benefits that we achieve in the acute phase in a 6 months phase.
So now we get into that balance of research and clinical practice, right? We need the randomized controlled trials for this to be in the guidelines for everybody to recognize it. But there are millions of individuals right now not seeing adequate treatment for their depression, not seeing their anhedonia improve. So for those individuals, when you have results like this, results like the KIND study out of Ohio State, do you think it's enough to say, look, we don't have the randomized controlled trials, we're not in the guidelines, but this is something everybody should consider for that patient? Would you agree with that statement, or do you think that's too strong?
I agree, partially agree. I think the first thing we can say for sure is stop doing what is bad for your brain. Like, stop eating ultra processed food and lots of sugar and lots of carbs. We know for sure that this is bad for the brain, this is bad for the body. And we are still dealing with those things. I was very happy to see that there was a shift in the way that our policymakers are thinking about, like, the food pyramid. But we want to go a bit beyond that, in the way that we have, uh, healthy food, less expensive than it is today, more affordable for our patients. So that's the first thing, the first part. The second part is that I think everyone should deserves to be informed about this possibility, because some of our patients, they don't want to take medication. They want to try. And is their choice to choose something that is promising, even all the evidences are not there yet. I think people should have, like, their preferences respected when we talk about, like, eating or the ketogenic diet.
Fellow mental health clinicians and healthcare providers, you now have access to a suite of free CME lectures on metabolic psychiatry and metabolic health. Each of these CME sessions provide insight on incorporating metabolic therapies for mental illnesses into your practice. These CME sessions are approved for AMA Category 1 credits, CNE nursing credit hours, and continuing education credit for psychologists. And they're completely free of charge on mycme.com. Now back to the video. Yeah. And when we talk about diet for depression, frequently it comes back to the Mediterranean diet, right? Because that was showed in a study back in I don't know when it was published, like 2017 or something like that, compared to sort of control diet as usual, that moderate depression could improve with a Mediterranean diet intervention. How do you think ketogenic diet compares to Mediterranean diet as an intervention, knowing that they haven't been studied head to head? So it's really sort of hypothesizing and exploring, but what do you think?
Yeah, what happens is that Mediterranean diet is what we have a randomized controlled trial, that we have a controlled trial, and we don't have this for a ketogenic diet. But the effect size in that trial was very small. So suggesting that Mediterranean diet may be beneficial, but not very powerful. Actually, when we talk about reduction of symptoms, this is very different. When we take a look in the literature and in the studies we have available now, the effect size of ketogenic diet is much larger than what we saw with the Mediterranean diet. So this is one thing. And the other thing is that, at least in mood disorders, we know that the most important predictor of adherence to any intervention is the perception of improvement. If the patient doesn't see an improvement, the patient is going to stop taking medications, to stop go to the psychotherapy, and to stop doing any diet. And this is something that we know from the studies with Mediterranean diet. The adherence, especially in the is very, very small.
And it really makes a lot of sense the way you explain that there is an effect, but the effect size is small, because compared to a controlled diet or diet as usual, anything that cleans up that diet is going to be beneficial. But what's different about ketosis is providing ketones for the brain, completely changing the metabolic effect and really the majority of the brain energy usage. That you don't just get by cleaning up the diet. So that would make sense that's why we see the higher effect size. So of course, hypothesis to be learned more of in randomized controlled trials, but certainly makes sense from a mechanistic standpoint. Now, we're talking about diet. This was a dietary intervention, but we also know other lifestyle factors can impact mental health and depression, whether it's physical activity or sleep or stress management. You can't study them all in one study. Was there any discussion about that in the protocol or with the subjects of the study?
Yeah. So what happens is that we, of course, do not actively provide like exercise combined with the diet. But we see that some patients, as they feel more energy with the diet, they naturally start to exercise a bit more. What we are doing, we are measuring that. So this study has a lot of secondary outcomes, which we did not analyze yet. But for example, most of our subjects, they lost a little bit of weight. We made calculate the diet in a way to not, to provide them enough calories to not lose a lot of weight, but some of them lost a bit of weight, and we controlled this in the analysis. But we have the data from the exercise. We have a lot of data about the eating behavior, because that's another thing when we talk about, for example, prescribing a diet to someone which might have symptoms of eating disorders, which is very common in depression. Some people were afraid that it would be a trigger for compulsion or things like that. So we have all this data. We did not observe any effect, any dysfunctional eating behavior, but we have this measured too. So all these lifestyle factors, we did not combine it with the ketogenic diet in the intervention, but we are measuring them. So at least we can report that.
Right. And that makes a lot of sense too. So you mentioned randomized controlled trials, you mentioned further studies. What are you working on in your lab?
So at this point, we are working on a project with an RCT with ketogenic diet, and plus this maintenance phase of 6 months for everyone who get a response.
Is it still remote? Can people join from anywhere, or do they have to be local now?
It is still remote. We are trying to use the same protocol. This was a nice experience. Canada is pioneer in remote delivering interventions remotely because of the geographic of the country. So, and at this point, a lot of patients, they prefer to be seen virtually. Is easier for a lot of people instead of visiting a professional in person. A lot of people have this preference.
Yeah. So where can people go to learn more about the study if they're interested?
So we have an email called keto at queensu.ca.
Very good. So they can just email you if they're interested, and they'll get more information.
Yeah.
And how about you personally? Are you on social media? Are you places where people can follow you and learn more about your work?
Oh, people can follow me on Instagram and on X, on Facebook, mostly on Instagram.
All right. Very good. Well, thank you so much for joining me to tell us about this incredible study, and I look forward to hearing more about your future work.
Thank you. Thanks a lot, Bret. Bye.
Thank you for watching. If you want to see more, check out these recommended videos. Also, if you haven't already, don't forget to subscribe to our channel to stay up to date with our content and help us expand the movement. And if you want to sign up for our newsletter, access our resources, read the latest research, or check out the Think Smart framework, click here to visit our website. See you on the next video.